Alrighty. Good morning, everyone. Happy Friday. Thank you so much for joining us today for our monthly Northwestern Medicine Healthcare AI Forum. Today, we're super excited to have two speakers joining us from UCLA. So, first off, we have Dr. William Shu. He's a professor of Radiological Sciences and Bioengineering at UCLA. He's a informatician focused on maximizing utility of multimodal data to treat and detect cancers earlier. And his lab harnesses AI ML techniques to integrate and transform multimodal data into really actionable knowledge. And we're also super excited to be joined by Luoting Zhuang, who is a fourth year PhD candidate in medical informatics at UCLA, and her work focuses on developing robust deep learning models for medical imaging, precision medicine, and specifically around extracting clinically meaningful biomarkers from longitudinal data and then integrating that to improve the early detection of lung cancer. So, really ambitious, involving a lot of different types of work. Super excited to have them. As a reminder, please put all questions in the Q&A function. And at the end, after both Dr. Shu and Ms. Zhuang have had a time to give their presentations, we'll open up and I'll moderate for discussion. So without further ado, I'll hand the virtual microphone, I guess, over to Dr. Shu. Dr. Shu, thank you so much for joining us.
Thank you so much, Kathy, for the wonderful introduction. And hello, everyone. It's great to see you guys virtually and to be back this year's round of Healthcare AI Forum. So thank you so much for the invitation. Um, we're going to tag team this. So I will start off, hopefully for about 20 minutes to talk a little bit about what we do in our lab, specifically around multimodal AI and its applications in cancer screening. And then I'm going to pass it off to Lottie, who will talk very specifically about a paper that she recently published looking at how we combine text and imaging data to improve lung nodule malignancy prediction. And so, with that, let me just start by motivating why having multimodal model is important. And so, I think all of us had the unfortunate experience at some point of probably having some kind of car problem. And so, oftentimes with car troubles, there's a lot of different things that could go wrong. But when we bring it to a mechanic, there's things that tell them what potentially could be the issues. That could be based on the sound of our engine, maybe a warning light on our dash. There's diagnostic codes that the car actually generates, your description of how you were driving, or maybe what something that happened, and then of course the mechanic's visual inspection. Now, if we think about just taking one of these data points, like just getting a diagnostic code, it may not encompass everything that we need to know about the situation. So the car may say, yes, I have an engine error, but it may not reveal that it was caused by an accident that the driver, hit some railing. And so I think with that, having complete information and multimodal data is helpful to really give a complete picture so that a mechanic can be able to accurately diagnose a situation. Same thing for clinicians and for medicine. It's really important for us to be able to harness a lot of the multimodal data that's out there in healthcare to really improve our ability to make better decisions. And so in my lab, as well as many labs are looking at multimodal data, we're very interested in pulling clinical electronic health record data, molecular data, imaging data, pathology data. All of these data sets have their own challenges. They all have different ways that they're represented. And the question is, how do we build multimodal models that are not just this black box, but also that is reliable, that can be explained, and also ultimately to be applied to different clinical tasks like understanding who should be screened, what the diagnosis of the patient is, and potentially even treatment recommendations. And so the QR code leads to a really nice review paper that actually Lottie put together along with other colleagues. And the goal here is really to improve our ability to take all of this information that's routinely generated to make better decisions. And so a lot of my work is applied in lung cancer and multiple cancer areas, but I'll focus on lung cancer. So lung cancer is still the leading cause of cancer-related death. 50% of people diagnosed with lung cancer do not qualify for screening. And so right now, we have a risk-based population screening program where, based on smoking history and age primarily, you qualify for screening, which many of these patients who get lung cancer later on may actually not qualify in that range. And also that despite this early detection, there are still a lot of patients with even early stage disease who later develop recurrent and metastatic disease. And so from a radiology perspective, so I'm in the Department of Radiology, there's actually a lot of interest in trying to understand, can we use images and other pieces of information to help us better understand who has cancer and also whether that cancer is aggressive. And so a lot of my research is tied to the idea that when we have these images, like here's a specific zoom-in image of chest CT or computed tomography scan. At some time point when the patient got this scan, let's say in their baseline uh, low-dose scan for lung cancer screening, there may not be anything there. That blue circle is really not showing anything. But over time, the patient may evolve to have a nodule. And the question is that what happens underneath, right? We see these changes in the images, but clearly there's something biological that's going on. It could be due to different mechanisms. Many of you may be familiar with the hallmarks of cancers, the idea that, there's a lot of biological changes that happen for cancer to become, to evolve from something that may be benign and indolent to something that is cancer, and ultimately be able to interpret that through different types of signals like getting it from the blood, getting it from pathology, and so forth. And so we're very interested in trying to tie the biology to what we see on images. And using that, we're trying to apply it to the management of lung cancer. So questions like who should be screened? Can we improve upon the current clinical risk criteria to identify patients who are at highest risk of lung cancer? If we do see something abnormal on the computed tomography or CT scan, is it malignant? And also, can we predict even before surgical resection whether or not the tumor that we have identified that we've biopsied and confirmed as lung cancer is actually aggressive? And so there's been a lot of interest in this space. And I'll just mention a particular work that came out of MGH in Boston that talked about this model called Sybil. And so Sybil is basically a imaging-based deep learning model that was trained on a large set of natural lung screening trial images. And what they did was they tried to train it to predict 1 to 6 year lung cancer risk. And so basically what you're seeing in these curves, so many of you are familiar with these type of receiver operating characteristic curves, you'll see that each of the different lines represent different years and predictions. And you can see that for a year out prediction, meaning that the risk of a lung cancer for within 1 year, and this is in the same population that they trained on, you can see actually that it does quite well. So it got an area under the curve of 0.92, and it goes down to about 0.75 for 6 year prediction. But ultimately, what it's showing here is that it does quite well to predict lung cancer risk. Similarly, they applied it to then their local population, which they did not train the model on, and they saw that the model was actually relatively consistent in its performance. It dropped a little bit, but generally speaking, the performance was very was similar. And then what was very interesting is that then they actually then ran it on a wholly different cohort. So this is now a cohort in Taiwan that doesn't have the same screening criteria that we do here in the United States. And so for them, they may not be they may be a never smoker, but then they may have family history of lung cancer, so they come in and they can get a CT scan. And so they ran their model on that cohort, and they saw that the model actually performed, again, very similarly. So what this interestingly pointed out for this type of work is that these type of imaging-based models are picking up something. And the work did not directly go into exactly what that was, although they did train it on identifying nodule-like structures, and so that played a role in it. But ultimately, the fact is that there is signal in the images that could be useful to predict lung cancer risk. And so this has drawn a lot of interest, and in terms of how AI could potentially help us detect early signs of lung cancer even before radiologists be able to call it. And there was a lot of hype around this. And what I want to do in my talk, really briefly, is to kind of highlight some of the work that we're doing in this space, but ultimately to drive it with three key takeaways. One is that in order for us to do this well, we really need good, robust data. We also need, and this is my premise, is that multimodal data will help us because a single modality that just like looking at just purely the images may not be enough to really achieve the performance we need clinically. And finally, being able to rigorously validate this so that we know that the model is not just learning things that are not clinically or biologically relevant. And so let's start with the foundation. So if you build a skyscraper, you need to have a solid foundation. And similarly, if you're building multimodal marker, you need good data and a very robust population to do this type of model training. And so some of the challenges around this is that when we talk about multimodal data, oftentimes it's unpaired, meaning that the patient may have one type of data, but when we try to lump in multiple different types of data, let's say blood, as well as clinical data and imaging data, the number of patients that have all of that consistently collected gets fewer and fewer. And so, how do we collect the blood and bank them in a way that is adequate for this type of biomarker development? How do we collect the clinical history so that's complete? And oftentimes, electronic health records are incomplete. How do we ensure that the timing between the blood and other clinical information is well captured? Being able to do this at scale so that we can get sufficient sample size, and ultimately to make sure that we're following these patients, and if they even leave the health system, that we still know that they have cancer diagnoses. Otherwise, we have lost a follow-up. And so here at UCLA, we've established a workflow to try to do this. We call it integrated diagnostics, where we've basically been looking at patients who are coming in for both screen as well as incidentally detected indeterminate pulmonary nodules, which are nodules between the size of about 6 to 30 millimeters. And we're basically collecting all of their imaging. We're collecting samples of blood, nasal swabs. We're also looking at getting their biopsy tissues and banking those when it happens through an imaging guided biopsy, as well as then following them over time to get their cancer outcomes, as well as further treatment information. And so with this information, we can then structure it. So we're trying to extract quantitative features from the images. And so here we're using what we call radiomic features, where we're basically it's a set of formulas that you can use to generate from this green region of interest some distribution or some quantitative values about this region, so it describes it. We also can use neural networks to actually extract features. And so foundation models, which many of you are familiar with, that's a type of large scale neural network that's extracting features. And we can do this for other types of data like molecular features as well. So similarly, we can do some bioinformatics type analysis to pull out copy number aberrations, mutation burden, and so forth. And all of this is being changed as we go along, right? Because as new foundation models come out, and so there's been several publications, even in the space of CT lung chest CTs recently. There's just a lot of work in this space. And so we're looking at all of these models to try to extract relevant features. And also, we're looking at the clinical data. And so, some very, what we thought were very straightforward things like smoking history are actually things that are not consistently extractable. And so, we've actually been looking at how do we characterize things like quantitative smoking history, smoked a year smoked, pack years, cigarettes per day, et cetera, and being able to then use a model. And so, in this case, we're using a bidirectional encoder type representation where we're essentially training these models to extract these features. And we're seeing that, compared to, for example, a rule-based method, which was previously published, versus an open source generic GPT type model, our BERT model that was customized for this clearly does better. And so these are types of tools that we are trying to essentially tailor to get relevant information from the medical records so that we can feed it into our models. Now, I love eating, and so some of the things that my analogies will tie back to food. And so here I want to make the point that, asked me like 15 years ago whether or not I thought tacos and Korean food would have gone together, I would have said that sounds weird. But clearly, over time, it has shown that kimchi tacos are excellent. And so, multimodal data fusion, similarly, is the fusion of different types of data. It really, improves detection classification beyond what a single modality can achieve. And so there's a lot of different ways that data can be fused. And so there's this really nice review paper that I participated in, but Arvind Rao, who's at University of Michigan, led, and the QR code points you there, which talks about different conceptual ideas around multimodal fusion. So it could be taking two modalities, A and B, and turning it into the same representation, so standardizing it. It could be actually taking features from these two modalities and fusing them or combining them, and that's where I'll spend a lot of my time. And there's other things like translating, like, for example, moving features from a CT scan to a PET scan and vice versa. Um, but like I said, fusion is a particular interest because it really helps us understand, well, how do we combine different modality features in an effective manner? And so here are three examples that you will typically hear. So we have what's called early fusion, which is we extract the features from each modality, and then at the very beginning, we combine them together to make a prediction. We also have what we call late fusion, which is taking each of the modalities and building independent models. So it's a model that's generated from that modality, and then we're then combining the model outputs and aggregating it into a single prediction. And a lot of work these days are in this intermediate range where it's somewhere in between, where we're actually training models as well as features collectively to combine these features. And so one example I'll give is a work that we're trying to do in the space of indeterminate pulmonary nodules to combine a blood test, in this particular case, a cell-free DNA methylation test with imaging that we can extract from the CT scan. And so you can see here that there's foundation model features, there's pi radiomic features, as well as methylation features that we're extracting. And we're really just trying to come up with a risk of malignancy for this type of indeterminate pulmonary nodule. And so with that, I'm not going to go into too much of the details other than to say that we extracted a bunch of radiomic features, as well as used a foundation model to extract another 4,000 features from the scans. And these were all pre-trained because of the limited size of sample that we had for the multimodal data set with the blood and imaging. And then for the methylation features, we did something similar where a lot of this encoder decoder was trained on cancer genome atlas type data. And then through that, we identified 128 methylation feature embeddings that we then used in a classifier. And really briefly, what we're showing in these bar graphs is that you can see here that we're doing no fusion. So that's individual modalities independently with early, intermediate, and late fusion. And this is the area under the curve as a very simple metric. And here the colors just represent different combinations of the different data types. And what you'll see is that the best performance, at least in terms of the bar, is the intermediate fusion, where you combine all of these different imaging and methylation features. Clearly, you also see that the confidence intervals are still quite broad and wide. And so there's still a lot of work to be done to try to get this going. And this sample size was about 100, so it's relatively small. And so what it is showing that is promising and that there is intermediate fusion is a approach that sounds like it could get us sort of the best of all of the different modalities. And we can also see that interestingly for this type of model, even though we predicted stage 2 to 4 type cancers with better performance, stage 1 actually was also very good, which in this sense is our target, right? Because we ultimately, as part of a screening test, would like to try to detect these early stage cancers. And so Lottie will talk about her methods a little bit more detail, but I just want to allude to her work in terms of combining the clinical text as well as the images to make more explainable models. And so she'll go into that in her presentation. And also just highlight that the idea of how we combine these multimodal features is still a very much open-ended question. And so we're investigating ways to provide a framework to actually combine all of these features together in an optimal way. And how do we do that? So we're looking at information theory. There's a method called partial information decomposition that has been published from a group in MIT that really could be helpful in guiding us in looking at the information value provided by each of the modalities. Now, finally, I'll just say something about training and validation. So, obviously, when you take karate and you move through the different, progress through different levels or belts, similarly with AI, we need rigorous and systematic training and validation to make sure that the models are learning biologically meaningful patterns instead of just shortcuts. So, what I mean by shortcuts is that AI models are quote unquote lazy. If you give it a lot of data and it show it some images and make it predict things, sometimes it gets things wrong because, for example, like in this case, maybe the problem is it describes the green hillside as grazing sheep because this background is always seen with the sheep, so it just seems like it infers that there should be sheep here. Here, there may be some hallucinations where if you actually add a few features that tricks the model in thinking that there's a teapot, then it will recognize a teapot even though those features may not be visible to the human. In healthcare, this has happened before where, there's been really good chest x-ray models, but those models are actually focusing more on these type of tokens that hospitals are using rather than the lung and the pathology in the lung itself. And so what we're trying to do in this space, one of my students is very interested in looking at using contrastive learning to try to look at the relationships between different modalities like digital pathology as well as the nodule that the sort of the specimen and the image is from, so that we can try to see if we can find and draw correspondences between what we see on the pathology side versus the imaging. And another one that I'll just mention is that there's been a lot of discussion and talk about how we can use paradigms to try to do validation. So this is a paradigm borrowed from the Early Detection Research Network, where you can go through different phases of biomarker validation from just the discovery and validation, where we're looking at it from a retrospective small cohort, which is typically what we do in academic research. But ultimately, we need to be working towards retrospective longitudinal analysis as well as prospectively trying this in the target population before we actually get this to clinical practice. And so phase 3 and 4 type of evaluations are very challenging, but these are ones where in order for us to have a robust model, we need to go through this in a systematic way, just like how drug development and drug testing is done. And so some concluding thoughts. The first one is that we're very interested in my lab shifting from population-based to precision cancer screening. There's a lot of factors beyond even the ones I mentioned, where, for example, in Los Angeles last year, we had the big fires. There was a lot of pollution that came out of that in terms of pollutants in the air, the smog, chemicals. And so that will affect lung cancer risk. And so being able to combine this and to monitor this using blood, biospecimens, as well as imaging is really one effective area that I think multimodal models can help us. Also doing this over time. And so there's been a lot of interest in using blood tests and collecting them longitudinally to see if we can measure disease and response to treatment. And certainly this is something that we're interested in my lab from the imaging perspective as well. But there's a lot of challenges too, such as how do we combine all this information and make sure that the measurements are consistent. And finally, there's just a lot of methods out there. And so again, the review paper by Lottie, looking at these different approaches, both on a deep learning, machine learning scale, but also from a traditional statistical analysis on how to represent multimodal and longitudinal information. So I really encourage you to check out this paper if you're interested in this space more. And so finally, just as a quick takeout, AI enables the discovery of multimodal biomarkers. It really does help us combine the information so that it goes beyond just any single modality. But we really do need robust data and infrastructure to help us build these type of models. And we do also need very rigorous and transparent validation. And so these are things that our lab is very much interested in pursuing. So one last plug is a Substack that the lab has just recently started called Navigating the Multimodal Frontier. And actually Lottie is next in posting. And so if you want to kind of keep up with our lab as well as the sort of the work that we're doing, please do come to the Substack and feel free to subscribe. And with that, I just want to acknowledge the lab as well as the funding, and happy to answer questions at the end if you leave it in the chat. But otherwise, let me pass it on to Lottie for her part.
Awesome. Thank you so much, Dr. Shu, for that sort of tour de force presentation. Reminder to people to Put questions as they come up into the Q&A, and we'll get to them at the end. All right, and then handing it over to Lottie.
All right. Yeah. Hi, everyone. My name is Lottie, and very excited to be here to share our work on vision language model-based semantic guided imaging biomarker for long nodule malignancy prediction. So in lung cancer screening, low-dose CT have been providing non-invasive and detailed insights into lung nodule morphology. And based on those images, radiologists can decide whether a patient should undergo a biopsy or return for a follow-up screening. And recently, computer-aided diagnosis systems have offered benefits in facilitating the early and also accurate detection of abnormalities by extracting a wide range of imaging features from the low-dose CT scans. So there are different types of features. First of all, semantic features are the characteristics of the nodules and also the surrounding areas, usually manually annotated by radiologists based on their domain knowledge. So they can include like general features, for example, nodule size, nodule shape, and also internal feature trying to describe if there is necrosis in the nodule or if there is an airway passing through the nodule. And also external feature, trying to see if there are a lot of like vessels around the nodule, trying to provide nutrition to the nodule, or if the nodule is attached to the pleura. So such models trained on semantic features are typically easier to interpret and also align with like clinical understanding, but they also face challenges when scaled for clinical use because they require manual annotation during the inference. On the other hand, these features are extracted from deep learning models, which can offer the ability to automatically extract meaningful features. But the problem with that is that they have this black box problem, and also they prone to learn spurious correlation, as Dr. Xu just mentioned. Therefore, it makes deep learning models very hard to generalize to external data sets. So you can see how these two types of features complement each other. The question lies in how we can combine the strengths of using two types of features. So in this study, we're trying to use semantic features to guide deep learning models to learn clinically relevant features that can be more explainable and better generalized in predicting long nodule malignancy risk. So in this study, we used a vision language model known as a contrastive language image pre-training, CLIP. So it is a foundation model that had been trained on 400 million image text pairs collected from the internet. So the model is trying to learn to align natural images with their corresponding captions. For example, here, a photo of a dog and the phrase Pepper the Aussie pup can be mapped to nearby representations, while those unpaired images and text, for example, the photo of the dog and a text describing a car placed farther apart in the latent embedding space. So this framework is particularly suited to our setting. We can replace natural images with medical images and the text with the semantic features. So by doing so, these semantic features, which represent our medical domain knowledge, act as a form of a regularization or guidance. So this alignment encourages clinically meaningful structure in the learned representation space. However, there can be several challenges in adapting the CLIP model to our medical imaging setting. First of all, the CLIP model is trained on natural images, which are 2D, but for our medical images, specifically the CT scans we are using, they are in 3D format. To address this, we adopt a 2.5D multi-view approach. So first of all, we crop a 50 by 50 by 50 millimeter around the nodule. And then we crop on the crop nodule, we slice 2D images from 9 different viewing directions. So this strategy preserves the 3D structure as much as possible and also allows us to use the pre-trained 2D image encoder from the original CLIP model. Another challenge is that the text encoder requires text input, but the semantic features we are using, they are in a structured tabular format. So to solve this problem, we use generative AI. Specifically here, we're using Gemini to turn the semantic features in a table format into text that look like a radiology report. So our training data actually comes from 2 different cohorts, which we will explain it in the later slides. But these 2 data sets have very different semantic feature. And after we discussed with radiologists at UCLA, we first harmonize those features to make them more consistent. And then we use those features and then a prompt to guide the model to generate radiology style text. So here is the overall vision language model architecture. As you can see, for each of the 2D image from the 9 different views, we pass it through the image encoder to get the image embedding. And we use a attention module to aggregate all those features into single feature embedding. Similarly, for the radiology report like text, we input it into the text encoder to get the text feature embedding. And we use the clip loss to align the corresponding image and the text together. We also add additional classifier layers after the feature to predict lung cancer risk within 1 year. So the benefit of this architecture is that even though we use a semantic feature as guidance during the training, we don't really need any manual annotation during the inference. So the only thing required during inference is the nodule crop itself, and it will be able to give us the prediction of whether the nodule is malignant or benign. So here is our training data set, which mainly come from 2 data sets, NLST, which is a screening cohort with mostly low-dose CT scan, and also from LIDC, which contains both screening and incidental nodules, and the CT types are low-dose CT and diagnostic CT. So we can see in total, the number of nodules we have is slightly less than 4,000. But as many of you may know that for CLIP model, it's based on transformer model, which have a lot of trainable parameters. So training or fine-tuning such model on a small data set can lead to overfitting. But another approach people usually take is probe tuning. So they freeze the encoder and only fine-tune the linear layer after the encoder. It reduces the trainable number of trainable parameters, but the problem is that when the pre-trained data sets and the fine-tuning data sets, when they're very different, this approach may not work very well. So in this case, we are using a parameter-efficient fine-tuning method called LoRa. So it freezes the encoder and inserts trainable low-rank matrices into each layer of the vision and the text encoder. So this not only reduces the number of trainable parameters, but also better adapts to a new domain. So here we have medical imaging domain, as some of the encoder parameters can be trained. So this is pretty much of how the model architecture look like. We set aside a small part of NLST data as held out test set, and we perform 5-fold cross-validation on our training data and evaluate models on 3 external cohorts, each of which is collected from very different clinical scenarios. For example, Duke lung cancer screening data is also a screening cohort with low-dose CT scan. We also curated a cohort from UCLA Health. It's a very unique cohort which contain never smoker and incidental nodules. And the CT are low-dose CT scans and diagnosis CT. We also have like lung X challenge data. So these patients are high risk because they have already gone through like biopsy. And the CT scan they have are diagnosis CT and contrast enhanced CT. And we are also trying to report comprehensive evaluation metrics, for example, AURC and AUPRC, which are the trade-off between sensitivity and the specificity or precision at all of the thresholds. However, we find that not all of the thresholds in AURC and AUPRC preserve clinical meaning. So in lung cancer diagnosis, we would like to capture as much or as many cancer as possible, which means that we need to have a pretty high sensitivity. So here we are trying to present the precision and false positive rate to show how the model performs in terms of reducing false alarms when we achieve high recall levels. We also benchmark our dataset against 3 state-of-the-art models, which include Sybil, which Dr. Xu just mentioned, and also Venkatesh paper. So these 2 papers are imaging-based models, and they are trained on NLST data. But for Sybil, is trained on the whole CT scan, and Venkatesh paper, the model is trained on the nodule crop. And DeepIPN is a model that combines both the nodule crop and also they include like clinical feature and semantic features, but they use a co-learning approach. But in our case, we use like a vision language model approach. So here is the lung cancer prediction performance on patient level. So there can be multiple nodules from a patient, and here we are just taking the maximum of the probability to present the risk score for the patient. I will go over the result one by one. In the NLST Haldao test set, our model outperforms deep lung IPN model in terms of AURC, AUPRC, and our model also has a lower false positive rate and higher precision across all recall levels from 0.6 to 0.9. We didn't compare our model to Sybil and Venkatesh paper here because there can be some overlap between their training cohort and this specific Haldao test set. In this long X cohort, our model still performs the best in AURC and AUPRC, and also achieves better results in reducing false alarms in most of the high recall levels. So interestingly, although our model did not train on contrast enhanced CT, it still performs pretty well in long X data. In this Duke lung cancer screening data, our model achieves the highest AURC, but has a lower AUPRC compared to deep lung IPN. And deep lung IPN performs better in recall levels of 0.6 to 0.8. One possible reason behind this is that Duke lung cancer screening study uses a nodule detection algorithm to identify nodules. They do have like some radiologists to review some of the detected nodules, but a certain part of the nodules or images or the center did not correspond to the true nodules. So maybe like our model is more sensitive to that. While deep lung IPN performed better in Duke lung cancer screening data, in our never smoker UCLA cohort, the performance dropped dramatically, but our CLIP model still remains strong in overall metrics like AUPRC, AURC, and also in reducing false alarms in this never smoker cohort. And another special feature of CLIP model is the zero-shot inference. Although the model is not trained to explicitly predict the semantic features, we are still able to provide the probability. So for example, we can input like two sentences. The nodule is well marginated, the nodule is poorly marginated, and we get the text embedding for each of the sentence. And we compute the similarity of the image feature with each of the text feature, and we are able to get the probability here. So you can see on the table on the right, our model performs well in predicting general and external nodule features, but it performs worse on, like, for example, shape and most of the internal features. So this might be because of like strong class imbalance for rare internal features. For example, you can see for necrosis, there are only 0.4% of them have necrosis in our data set. And also, another reason could be that not all of the features are equally important for malignancy prediction, and maybe some of the features might dominate the other features. So for the main takeaways for this study, first, by incorporating semantic features, our model learns clinically relevant information, and it can achieve improved performance in lung cancer diagnosis and also help reduce false positives when maintaining very high sensitivities. And such alignment strategy also result in better generalization, as we show in our results. It can better generalize to data sets collected from different clinical scenarios. And also, compared to other imaging models, for example, Sybil and Venkatesh paper, we only use 1/10 of the nodule for training. But because we incorporate this domain knowledge, we're able to achieve results that are comparable to or even surpass their performance in lung cancer prediction. And the fourth one is that the zero-shot ability of the CLIP model improves model explainability and allow us to predict semantic feature without actual training, and it can help clinicians better understand the model outputs. So lastly, our model is designed to scale effectively without requiring the annotation of semantic features after the model is trained. So it can be adapted for widespread use in lung cancer screening programs and other large-scale healthcare settings to facilitate early detection of lung cancer. Yeah, thank you so much for paying attention. And if you have any questions, feel free to ask in the Q&A and also reach out to me through the email. And we have the QR code for the paper and also QR code for the code. We have the code and also the weight, model weight on the GitHub. So feel free to try this model on your private cohort. Yeah, thank you so much.
Awesome. Thank you so much, Lottie, for sharing that in, I feel like you really explained some complex concepts in a very understandable way there. And also just congratulations on the paper and the work. I think it's super cool that first of all, you're really using all the information that you have beyond just, the image itself. And the fact that you looked at all these different cohorts that, like you summarize, some are non-smokers, it's like a really difficult and I feel like challenging challenging test for your model. So that's awesome that it performs so well and as you demonstrated, outperforms many of these very sophisticated state of the art. So yeah, kudos, bravo to you and the team for such great work. Just a very quick question as questions, start to come in through the Q&A, I guess for you, Lottie. What do you see now that you've built this as, kind of the next steps to take for this for your model?
Yeah, so because I am extremely interested in like longitudinal study, so here for most of the model I compare to and also our club model, it's only trained on single time point. So I am also interested in seeing like what if we obtain like the longitudinal cohort from an NLST and trying to capture like the changes in nodules, what if we are able to improve the performance in lung cancer prediction as well. Yeah, actually,
That's really
we are still working on that, and we hopefully we will have like a publication soon on that.
very
Yeah.
cool. I do feel like, definitely over time you get more information. And I don't know, this is my bias as the pulmonologist, but I have many patients that we follow with serial scans for a long time. So I think the trajectory is super, super informative. Sorry, Dr. Shu, were you going to add something?
Oh yeah, yeah. I was just going to say that I think this type of longitudinal modeling is there's a lot of challenges, right? And I think some of it has to do with just even making sure that you have to kind of follow up with the patient, but also just even between the patients, right? So some of the things that we're trying to address in our lab is, for example, when you get a CT scan and you get that scan over time even by the nature of getting the scan on a slightly different machine, or maybe even a different institution where they have slightly different settings, can affect the appearance of the nodule. And so, if you've seen enough of these CT scans, you'll know that the noise and the kind of the details may look a little different, and different radiologists have different preferences. And so, for AI, when they look at these images, they won't be able to tell the difference in the sense that this is noise and not biological changes. And so, how do we actually make sure that when AI extract the features and look at changes, and they'll find a difference, how do we tie that back to a biological difference, which is, I think, a key question, and one where I definitely think that, while we see a lot of promise in the models that are being developed, I just wonder, again, just like the question, the sort of the challenge I posed earlier about, the models actually learning about the token rather than the actual pathology on the lung. How do we ensure that, yeah, the model is learning the right features and that the change that it's detecting is actually biological?
That's a great question. I think that leads into a Q&A from Brian, who asked, how do you check which data types, for example, imaging, genomics, pathology, EHR, are actually driving the model's prediction? And how do you check when one modality or feature is disproportionately influential, and when one is really sort of dominating the prediction?
Great question. Lottie, you want to take a stab first, and I'll.
I guess it's still a challenge in multimodal fusion. And I think in one way to see like which feature is better is that using the PID that Dr. Xu just mentioned, that they trying to find if there's like complementary information in different data types, or if there are extra information from each of the feature that the modality can provide. I guess that is the something I can think of. I'm not sure if Dr. Xu has anything to add.
Yeah, and this actually goes back to one of the challenges I raised earlier, which is when we have these type of multimodal models, oftentimes right now, I would say a lot of the community is just doing trial and error, right? Where it's basically saying, okay, we have these modalities, let's just feed into this fusion model and, try early, late, and intermediate fusion and see which one comes up with the best performance. But I think that definitely there's better strategies to do this, partly both on even just the model training side, where each one of these modalities, they have unique information, but they also have overlapping information, right? And so, this is where with information theoretic kind of measures like entropy and other things that we could look into, we could actually try to quantify how much is there overlap between the modalities versus are unique, and then try to maximize the uniqueness of the modalities, which is really what we ultimately want to build our model. From a trained model side, right? So now this is on the other end where the model has learned on the data. Then your question about, well, how does the model weigh? Like maybe it's basing 90% of his decision on the genomic data and only 10% on the imaging, right? I think there are what we call post hoc, which is basically when you have a trained model and you start querying the model and to kind of interrogate it to see what it learned. This is what people often do when they talk about model explainability, where they're having a black box model and to try to understand what the model has learned, it's basically running all these like either sensitivity analysis or just bunch of queries just to see what the model outputs to see where does the model make a different decision when you give it slightly different inputs. And with that, you could also figure out, let's say if you maybe take out the imaging data and just use the genomic data versus you take out the genomic data and you show the imaging data, you'll start getting a sense of, okay, if the performance really drops versus only has a very subtle drop, you can see then that, okay, that's what's mainly driving the prediction. But I think this is not a one size fits all, and this is very much an open area of research for multimodal AI. So yeah, so I encourage you, happy to chat afterwards if you have other questions on it, but I think it's a great area to do research.
Thank you for that very thorough answer. And what one thing that you mentioned in the beginning is just sometimes it's really hard to just acquire all the data, especially some of the rare genomic, transcriptomic
Hmm.
sort of things that's not frequently clinically available versus, pretty much everyone has a CBC, BNP, things like that, sort of leads to just bias in the data sets that
Yeah.
you have. So it'll be really interesting to see over time, hopefully, as we build out more of these data sets that are labeled and sort of these techniques flesh out a little bit more. I have a little bit of an adjacent question, just as a again a practicing clinician. Sometimes what we come across is not one nodule, but two nodules. And the question is,
Hmm.
is there any model that sort of looked at these two nodule problems at the same time with the same clinical background? Because the question always comes, if you take them to bronchoscopy, do you go after one? Do you go after the most suspicious one? Both? If they're bilateral, you don't want to drop both lungs. So curious if
Right.
that's been explored in the literature or by you
That
guys.
Yeah, no, that's also a very interesting and I would say I haven't seen so I have seen models that have looked at the risk individually of individual nodules that you may see.
Mhm.
Oftentimes, we may look at it from the same lung, but looking at bilaterally, I think, models do kind of detect those and you can quantify it.
Mhm.
But that said, the relationship between the nodules, that's a very interesting question and one where because and this is just thinking out loud because we haven't really addressed much of this in our own lab, but one of the issues that we see is that, oftentimes when we have a lung cancer label, right? So the patient has lung cancer, it's actually not tied to like that the fact that we have these nodules all biopsied, right? Obviously, it would be very impractical to biopsy all of the nodules that may be even somewhat suspicious, right? Just to minimize sort of the intervention to the patient. And so I think the lack of, you know, I think, one thing that we would love to do is, if there's resections where you do have like
Mhm.
a sort of wedge of tissue that you could look at to maybe do some specific studies around that. But off the top of my head, I'm not sure if I know of too many studies that have looked into this too much. But Lottie, do you have any?
Um, Personally, I haven't like really looked into those studies, but I feel like that is like the challenge we have, like particularly in my study, because I want to identify which nodule is the one that got biopsy, but usually they did not record it in the data set. And when there are two suspicious nodules, we can't really decide, oh, which one is lung cancer and which is not. So yeah, this is a challenge.
Fascinating. Yeah, no, thank you. It makes me feel a little bit better that clinically sometimes I'm not sure
Yeah,
what to do. Sounds like we need more time and
yeah.
research into it. Well, thank you so much again, Dr. Shu and Ms. Zhuang, for giving this really fantastic talk. Awesome work. I put a link to Lottie's recent paper in the chat for everyone.